The next presentation is by Isabel Tol, who has a very interesting history of the fact that she's currently a core surgical trainee working in Dorset, having just come back from Sydney from working as a pediatric surgery in pediatric surgery, and she graduated from Oxford, and is going to present to us the management of postpartum hemorrhage, a systematic review. I mean, Isabel, thank you.
Hi, my name's Isabel, yes, and a little bit of a different background to lots of people here. I'm just going to start sharing my screen. So I, first of all, would like to say thank you very much for having me today. I started this review a long time ago with a couple of people who are in the meeting today. So I'd like to thank everyone in the group for their perseverance and patience on what's ended up being quite a long project. So we have performed a systematic review and meta-analysis of the postpartum management of hypertensive disorders of pregnancy. So as Laura spoke about earlier today, and lots of this is not new for anyone here, but the postnatal blood pressure spike on days 3 to 6 postpartum is significant and associated with significant maternal morbidity and postnatal hospital readmission. The management strategies that we have at our fingertips for this are varied and include things like pharmacological management as well as slightly more novel models of care for managing the blood pressure in this period. So our review aimed to look at the efficacy and safety of these different interventions on the blood pressure management in this period to help us inform clinical practice guidelines and future research. So this started as a Cochrane review and was prospectively registered there with a protocol that was published by the Cochrane Group. Our initial strategy was with their assistance. However, the shutdown of the pregnancy and childbirth trial register meant that our updated search was done independently in September of last year and this year. We looked at all randomized controlled trials that assessed women with postpartum hypertensive disorders of pregnancy that used any intervention that was aiming to reduce maternal blood pressure. So this encompassed quite a few different areas, and we didn't limit it to pharmacological means. So we split this into 4 different groups. Antihypertensives, and these trials again could be split into any antihypertensive versus placebo. Any antihypertensive compared to an alternative antihypertensive for a non-severe hypertensive picture, and then any antihypertensive compared to another antihypertensive for severe hypertension. Hopefully it will become clear as we speak about the results. We also looked at the use of diuretics, as well as the use of uterine curettage, which we know is not used clinically, at least in this country, and models of care. The outcomes that we focused on, so we looked at blood pressure control, which included poor blood pressure control, so this was persistent hypertension, any blood pressure values if they were reported, and the need for additional antihypertensives. We looked at maternal mortality and morbidity. If reported, we looked at breastfeeding at hospital discharge, the length of hospital stay in the postnatal period, and any postnatal readmission to secondary care. Again, when reported, we looked at the longer term cardiovascular outcomes and any patient satisfaction with care. So we screened our long list of identified papers with 2 independent authors and then subsequently extracted the data from these studies with 2 authors. We assessed the risk of bias using the Cochrane risk of bias assessment tool and assessed the certainty of evidence using GRADE, which someone has already spoken about today. And then we use random effects meta-analysis on RevMan for combining our data where it was combinable. So looking at our results, we identified 944 studies which culminated in 40 randomized controlled trials that were included in the review and meta-analysis. So looking at the risk of bias, overall it was relatively high risk of bias, predominantly in sections relating to blinding, and this was often related to the nature of the studies that were included where blinding was not possible. Unfortunately, this meant that often the quality of the evidence according to the grade protocols was low or very low based on some of this. So looking at diuretics, we found 7 trials, predominantly with low or very low quality evidence. We identified that blood pressure control was better in the groups that used diuretics in addition to antihypertensives. However, there was no significantly better blood pressure control if the diuretic was used as a monotherapy. We didn't identify any need for additional antihypertensives when pooling this information, even in the groups that used antihypertensives. And looking at some of our other outcomes, there was no difference in the maternal mortality, morbidity, or adverse events in any of the pooled groups. There was no difference in postnatal readmission when this was reported, and there was no difference in the longer-term cardiovascular outcomes when this was reported. When looking at that first group of antihypertensives, so this is antihypertensives versus a placebo, we found 3 trials looking at 3 very different drugs. So unfortunately, we weren't able to pull the information with the meta-analysis here. The only trial that was found to have a significant difference was that of the nifedipine. So we saw a lower blood pressure and a reduced need for additional antihypertensives in the nifedipine versus placebo group. And there was no difference in any adverse events that we saw in any of those 3 trials. Gets a little bit more complicated still. So when we looked at the antihypertensive versus another antihypertensive for the non-severe hypertension, we found 9 trials. This table is an attempt to summarize what's quite a complicated combination of trials. The light blue describes the intervention and the orange describes what the comparator was. So quite a wide range of comparisons, which obviously made the meta-analysis slightly more challenging, but we were able to draw some things together to analyze. So specifically, we looked at nifedipine in comparison to an alternative antihypertensive therapy. So these encompassed labetalol, hydrochlorothiazide, plus lisinopril, amlodipine, and enalapril. So overall, when we pulled this together, there was no difference in the need for additional antihypertensives when we compared nifedipine to all of these alternatives. However, when we did a leave one out analysis, because there's significant heterogeneity in this meta-analysis, we identified that SHARMA, when it was left out, significantly reduced the heterogeneity, and we saw that nifedipine was associated with a lower use of additional antihypertensives. Overall, again, a bit of a range of comparators, but we saw no difference in the postnatal readmission between nifedipine and the other pooled antihypertensives. When looking specifically at an ACE inhibitor versus nifedipine, so enalapril and the lisinopril plus hydrochlorothiazide, we saw that these were inferior to nifedipine with regards to the blood pressure control. We saw, in terms of some other comparisons, we saw no difference in blood pressure control or need for additional antihypertensives when labetalol was compared to amlodipine or when captopril was compared to methyldopa. And overall, we saw no difference in the maternal adverse events or the postnatal length of stay between any of the comparisons that was made. Looking at the severe hypertension category, so this was one antihypertensive versus another. We found 8 trials, a little bit more in common in this. So we saw labetalol versus hydralazine as a relatively common comparator, and we're able to pull some of these together. So when looking at blood pressure control with labetalol and hydralazine, we didn't see any difference between these two when we performed the meta-analysis. We saw that there was no difference in the need for additional antihypertensives when we compared nifedipine to other antihypertensives, and overall didn't see any change in the length of stay or the adverse events when any of the comparisons were looked at. So looking at uterine curettage, so we identified 4 trials, most of which used mean arterial pressure as a measure of blood pressure control. And when pulled together, we saw that there was no difference between curettage and usual care. None of these studies identified mortality or uterine perforation with uterine curettage. And when we looked into the detail of some of the laboratory values that were reported, we saw some small potential improvements in the ALT, the AST, and the uric acid at 24 hours with curettage, but this was only reported in a single study. When looking at models of care, we identified 9 trials. So we had 6 that were looking at the self-monitoring and self-management of blood pressure, which Laura spoke about a bit in her talk earlier today, as well as nutrition and cardiovascular exercise, tight versus liberal control of blood pressure, and one looked at neonatal sleep, all of which were compared to the usual care in whichever hospital the study was performed in. So looking at the single study on neonatal sleep, we saw that there was some improvement in the diastolic and mean arterial blood pressure with improved neonatal sleep. When we pulled together the information about self-monitoring or self-management of blood pressure, this included subsequent up or down titration of medication. We saw no short-term difference in the blood pressure control, but as Laura alluded to earlier, we did see that the blood pressure was lower at 6 weeks postpartum, so the longer-term cardiovascular outcomes were improved. And we saw that there was no difference in the adverse events in any of the studies. One of the best ones for the meta-analysis with these different studies was looking at postnatal readmission. And we saw that this didn't differ between the self-monitoring or management of blood pressure and usual care. So concluding what we found. So we looked at 40 randomized controlled trials that aimed at lowering blood pressure in the postpartum period, and overall found very low quality evidence relating to bias and single trials informing most of the outcomes. Specifically in relation to diuretics, we found that they might help in postpartum management when used in conjunction with an antihypertensive, but wouldn't be recommended as monotherapy. We found, as I think is a common theme in today's talks, that there is not sufficient evidence to recommend one antihypertensive over another. But some individual trials suggest that nifedipine is better than amlodipine or an ACE inhibitor. When we looked at uterine curettage, we found that this overall didn't improve blood pressure control. And again, as has been alluded to today, that the lifestyle change and the blood pressure self-monitoring appears to be promising in reducing the longer-term cardiovascular outcomes. Thank you very much.
Okay, thank you very much for that presentation. And